Nabil and I have an agreement that he was going to take 5 minutes of my presentation. So I'm going to do my presentation in 5 minutes. Very old man, very frail, diabetic, end-stage renal disease, came in with a non-STEMI, preserved EF. This is the angiogram. So the RCA is really good for his age and comorbidities. You can see the descending aorta, horrible, super calcified. His left system is the problem. Left main circ are good looking, LED diagonal are not. He does not have stents in the LED. He does not have stents in the diagonal. All of that is just calcium. This was prior to the era of IVL, and it was in a day that atherectomy was just not on the table. In addition, he was really, really frail. So we wanted to get him some good results. So we started with the diagonal. We ballooned it. It responded fairly well to the balloon. Stented, got good results. Started ballooning the LED, ballooning, and ballooning. Fairly good expansion, so really surprisingly better than expected results with just the balloons. Kept ballooning and ballooning. LED so far, so good. We put a long stent, struggled to deliver it, used the guide liner, brought another stent, overlapped it, and so far so good. We're a bit tired, and that's when the trouble started. So here we saw this, everyone in the room panicked. I know everyone says stay calm, but we were not calm. The nurse was panicking, I was panicking, everyone was panicking, except the patient. We called for an echo, we called for another doctor, additional nurse, mixed inotropes, started IV fluids. I brought the balloon, the same balloon back in. I asked the nurse to inflate it. She started inflating it, and then I started seeing contrast in the LED. So I looked at her and said, no, inflate, not inject. And then realized that she was struggling to inflate the balloon, and then realized that the balloon has ruptured, and that's what caused the perforation. That whole thing took about 15 seconds, 30 seconds. Felt much longer, but the heart rate did not budge, the blood pressure did not budge. The patient was very peaceful and very calm and very happy, which I thought was like, really does not make sense. I said, okay, 2 minutes and he's gonna crash. Echo machine arrives. I am focusing on bringing this defected, perforated balloon out, getting another balloon in, inflating the second balloon, and that took a while. We're opening a new balloon, etc. Echo comes in, hemodynamics are just great. We do an echo and there is just no effusion, nil, none whatsoever. Now the balloon is up at the site of the perforation. I thought, okay, let's just keep it up for 10 minutes. Maybe it will seal and maybe we'll have just nothing. So after 10 minutes, this is the angiogram. I say, okay, maybe we were really good. We sealed the perforation so fast that there was no effusion collected. Again, patient is extremely happy. We're chatting, really nothing wrong with the patient. I put the balloon back in, I inflate it, and the first balloon stayed up for 10 minutes. This I aimed for 20 minutes and I deflated at 18 minutes just because he started having chest pain and he started flipping his T-wave, and I really did not want to deal with clots and bleeding. So I thought 18 minutes is probably close to 20. We took a small puff and it was occluded, and I really could not understand, where are we perforating? Like, which chamber is this? So my colleague, who was very senior, suggested a lateral. I resisted this. I said, a lateral? I don't even know what I'm looking at in a lateral view. But I said, no, let's just do a lateral view. And it was really beautiful. So this is at an angulation of maybe 85. And you can see that the perforation is up. So we were debating, are we perforating into the LV? It is definitely not in the pericardium. The echo was pristine and clear. There is no pericardial collection. So essentially, where are we? And I don't know. What we did is, I said, okay, there is no more balloon inflation. That's not gonna work. We tried it twice and it's not gonna work. So what I did is I just kept the wire in place and we observed him in the cath lab for 45 minutes. he was rock solid. He was happy. He was talking to us about his life, and everything was just great. And I remembered the wisdom of don't treat the X-ray, treat the patient. So I convinced my partner that we're gonna do nothing. And he said, no, that's not okay. Let's just do something. I said, look, we're gonna keep him in the CCU. We're gonna keep a pericardiocentesis kit on his bedside. The fellow on call is very senior. He is more than competent in putting a drain. And I am on call tonight. If something happens, we'll deal with it. So we actually left it. This is the final angiogram. And I think, based on this view, that the blood is exiting into a space, maybe a pericardial fat, and then draining in a vein near the diagonal. So it's definitely not collecting, it's just some sort of an AV fistula. Overnight, he did very, very well. The next day, we got a CT scan to try and understand where is this perforation coming from or where is it going into, and we really couldn't. They just said, it's just too much calcium, too much stent, we can't really get any information for you. I have 1 year follow-up on him. He's doing very well. He deconditioned, he was very frail, and he's just deconditioned, but his echo looks great. His mind is there, but his body is just very, very, very frail. Calcium modification maybe would have prevented this. Maybe we should have avoided that last balloon. So it's just, trying to make things better. I think we overdid it. And I think just all cath lab staff should be very familiar with a perforation algorithm. So when this happened, it was a good test for us as a group. Are we responding very fast or not? Thank you.